I'll invite Paul to introduce himself as well.
Morning, everybody. I'm Paul Wood. I'm a GP in the city of Derby, and I'm also the clinical lead for urgent care for Derby and Derbyshire CCG.
So thank you for inviting us to do a presentation this morning. We're going to talk through NHS 111 first, and I'll just start sharing my screen, put some slides up. Just to let you know, there'll be some opportunities for us to explain what we're talking through and maybe some of the jargon. But if you're unclear at any point, just put a comment in the box and we will go through what that might mean in more detail at the end of the session. So bear with me while I share my screen. Is that visible to everybody?
Yes, Claire, it's visible.
Yes.
Lovely. Okay.
No problem.
So, thank you. I can't see your faces whilst I'm presenting, so if there are any reactions to something I'm saying or anything that you're unsure about, again, please just put it in the chat box, because I'm essentially blinded by the sun and by the presentation. I can't see what we're doing. So as I've said, we're here to talk through 111 first, and what we're going to cover is the differences between urgent and emergency care. Some of the challenges that we've been facing in the urgent and emergency care arena, some of which you'll be aware of through reading the news and through family that have probably experienced this. We'll talk through what's 111 first. I'm going to talk through what's changed in Derby and Derbyshire as a result of 111 first. And then the really important bit really is what does this mean for you as the public and the patients of accessing services? And then we'll summarise how to contact 111. And then there's a little bit which may seem a little bit random about what's an urgent treatment centre and when should it be used, but it'll become clear as we talk through just why that's really important and why that's linked to 111 first. And then we'll go through some next steps that we're working on in the programme, and a chance for questions at the end. Myself and Paul will be doing a double act. I'll do the first few slides and then Paul will pick up and we'll answer the questions together at the end. Okay, so let's go through what we mean by urgent and emergency care, because there is a fair difference. So urgent care is the range of healthcare services available to people who need medical advice, diagnosis and treatment quickly and unexpectedly for needs that are not considered life-threatening. And then emergency care is immediate or life-threatening conditions or serious injuries or illness. And planned care are routine services accessed through planned appointments or intervention in hospitals, community settings and GP practices. So we're going to focus on the urgent care aspect in this programme today, and it's important to understand that we're talking about the non-life-threatening conditions or serious injuries or illnesses, but things that may happen quite suddenly or over the last day or so that you do need support and treatment on. So in our urgent and emergency care services in Derbyshire, we have a number of different types of services. So we have NHS 111 and 999. 111 is more for urgent care and 999 is more for emergency care. So our 111 is a telephone and online service, and our 999 ambulance services is provided by East Midlands Ambulance Service across the region of the East Midlands, not just in Derbyshire. We have a GP out of hours service. So if your primary care service, your normal GP is closed, you can still access primary care, which is more of that planned or a need that's out of hours. And you'll be able to speak to one of our clinicians. And then we have urgent treatment centres too. We have the Derby Urgent Treatment Centre in the centre of Derby. We have Ilkeston Community Hospital Urgent Treatment Centre, Ripley Community Hospital Urgent Treatment Centre, Whitworth Hospital and Buxton Hospital both offering urgent treatment centre services too. And they're open 12 hours a day, 7 days a week, so between the hours of 8 AM and 8 PM. And they are our urgent needs services. And then for our emergency needs services, we have our A&E departments, one at Chesterfield Royal in the north of the county and one at Royal Derby Hospital in the south. Alongside that, we have multiple pharmacists and lots of GP practices across the whole range. Apologies, the sun's following me now, so I'm starting to lean a bit further over to one side. So with the challenges that have been facing urgent and emergency care, you'll have heard on the news, I'm sure, and may have personal experience, since we've been in the challenges of COVID-19 and the pandemic. Actually, in March, April last year, with the lockdowns, a lot of urgent care demand was suppressed, which meant we saw less people approaching services for urgent needs. But there were also a lot of people in hospital with coronavirus, which meant that we couldn't progress some of our existing services for urgent issues. And we know that this may have had a longer term impact upon people's health outcomes. So we are trying to remind people that our urgent and emergency care services are absolutely available for your need, despite the fact that we now have people in hospitals and hospitals are reportedly struggling with the amount of people in coronavirus beds and care. We are still open to be able to meet your urgent and emergency care needs. Please don't think that you can sit and wait, because you may actually get sicker if you don't seek the help that you need. So because of the pandemic and the ongoing waves, and we're in one right now, we have to make sure that our services, the actual building-based services, are safe for you to come in. And that means we have to limit how many people we can safely treat at any one time, and make sure that social distancing measures are really, really clear, which means that we cannot support, in the way we used to over a year ago, people walking into services and sitting and waiting, because what that does is it creates too many people in waiting rooms and waiting areas that risks the social distancing measures. However, what we have seen since the original wave in March and April is that the current level of demand for emergency care and some of our urgent care has been higher. And even through this lockdown, we see that continuing to be high, which puts increased pressure on our services with the amount of people coming in, and it makes social distancing more difficult. So some of the challenges that we're facing. What that means, though, is wherever we've had a challenge, we can turn it into an opportunity. And from the first wave in March last year, over this last year, the health service as a whole has been delivering more telephone and video consultations. And that is just as safe as being seen face to face in a building service. But what it does, it supports us to keep you safe and supports to keep our staff safe by having less people in the physical building and the waiting areas and the treatment rooms. Remote working, actually through video consultations and telephone calls, is actually showing that we've got increased productivity. And as today, none of us have had to leave our house to be able to attend this session. Whereas before we started doing remote working, there was probably more time lost travelling between sites. And so as a result, by sitting in one place and being able to talk to people through the internet or the telephone, we can provide more patient-facing capacity. So although it was a challenge, it's become an opportunity, and we're doing that really well across Derbyshire. And therefore, the delivery of more bookable appointments enable us to support patients and the public to access the right care first time from their initial contact. So the first time you contact services should be the time that we can put you in contact with the right service. And that's what we're going to be talking through a little bit more about NHS 111 first. So challenges are always opportunities. It supports us to deliver safe care in a different way. Okay, so on that side, we do actually need your help. We need you to support our busy services by going to the right place for treatment, and it's never been more important. What we're not suggesting is that you get a degree in being a medical doctor to be able to diagnose what you want. So we understand that you need support and guidance and advice to be able to access the right service, because as you saw on the first slide, there are a number of services that you can choose from. And this is where NHS 111 first comes in. So what we're asking you to do is call NHS 111 for immediate advice if you're concerned about needing urgent care. We're not saying do this if it's an emergency situation. You would of course call 999. We're not saying to do this if you know that your GP or a pharmacist can absolutely help you. Please still use those existing services because they're the right ones for you. But if you're ever unsure and you have an urgent need that isn't life-threatening, please contact 111. Okay. So what is 111 First? So it's a national programme, and that means everywhere across England is being asked to deliver this service, and it aims to improve the way that patients and the public access urgent care by making sure that you can receive the right care at the most appropriate setting first time, with the lowest level of risk of acquiring a hospital or healthcare related infection. So we've always had this need for people to consider using different services. We know a lot of people understand about accident and emergency departments and think that will be the right place, because not everybody is aware of the other services, and it can change quite rapidly sometimes about which services are available. So we've been wanting to create something that allows us to make the change for patients to use different services rather than just knowing about the accident and emergency departments. And the 111 First really is based on a principle called talk before you walk. So we're asking you to contact NHS 111 online or by phone to talk to a clinician or one of our trained call handlers, which will support you to understand which service is going to be the right one for you. Okay. And that's the talk before you walk principle. And what we want to do is reduce unnecessary attendances at an emergency department. So not all attendances, but the ones where other services can help you. And it supports us in maintaining our social distancing requirements and infection prevention control requirements, and it supports us to keep you safe. And it's really important to note that this is a ministerial policy. So this is not a little thing that Derby and Derbyshire has concocted. This is something that Matt Hancock, the Health Secretary, is very keen on, and we've had to provide a number of sometimes daily reports back up the NHS leadership chain into the Department of Health. So there's been a lot of national focus on this programme, and that's because there's a lot of belief that it's the right thing to do. So this is a really busy slide, and I'm not going to take you through every bit of it, but I want you to be clear that NHS 111 First is not a new service. It's actually a part of bringing lots of the urgent and emergency care services together, and work that's been going on for the last year or two. And we've been able to bundle it together really in a way that's easy to explain. So calling NHS 111 is not just calling NHS 111, it's calling what NHS 111 is giving you access to the whole range of services that we have available to support your urgent and emergency care needs. So should your need be determined to be an emergency, if you have called 111, your call is passed immediately to the ambulance provider. I want to give you that assurance. But also if you have a need that may require some specialist advice, 111 has access to the hospitals and our specialist advisors. We also have our call handlers and clinicians available to support you for self-care. You may not need another route to be referred elsewhere after calling 111. Self-care may be the option that you were offered. But equally, if you do need a face-to-face appointment for GPs, community pharmacists, mental health crisis teams, dentists, you are able to access that through calling 111 when it's been determined that that's the right service to meet your needs. So 111 will offer clinical advice for urgent care. So you are accessing clinicians, which is our doctors and our nurses and highly trained paramedics, to answer your query. They'll give you a clinical assessment and self-care advice. You may be offered a video consultation, or you may be offered a booked appointment at one of our face-to-face services. That's what the difference is going to be, and Paul will be talking through in more detail what that means for you. So again, busy slide, but what it means is by calling 111, you're accessing a wealth of information and a wealth of access to other services. I'm just going to hand over to Paul, and if Paul can indicate when you want me to change the slide, I'll do that for you.
Thanks, Claire. It's always hard to follow on when you've had such an excellent start to the presentation, and I certainly think you've done extremely well, given that you've had the sun in your eyes quite miserably there. In practical terms, there have been changes in Derby and Derbyshire really just to support this programme, because obviously if patients are going to ring 111, you need the service to work slickly and well. So there has been the recruitment of call handlers and clinicians to support the service. And then those call handlers and clinicians have access to arranged slots that are bookable in the services to which patients are going to be directed, so that there are bookable appointments in all of the UTCs, in the A&E departments. So every hour there are available appointments that 111 can slot patients into. And there are also bookable appointments in GP services too. In addition to that, there are the different ways of working, and so there 111 is using video consultations with patients, which can be very helpful if you've got a rash or some other lump or bump or something that's emerged, and that can be a very useful way of diagnosing and sorting a problem out directly in that way. And this approach is also being used in the UTCs as well. I think the issue which is picked up really from Claire's earlier slide really is about giving access to all services to the most appropriate service for the person, the patient. So we're trying to build the opportunities for EMAS to the ambulance crews when they're on scene to actually provide the best and most appropriate service for a patient, which in the past was often limited to either keeping the patient at home or taking them to A&E. And there are other services which patients can be directed to, such as general practice, such as UTCs, or simply fuller advice. And so that is being made more available. And likewise, access to specific departments or teams in hospital, if the condition has been agreed, can be dealt with directly, thus bypassing A&E and giving a shorter and smoother pathway for the patient. So we're building up those direct access pathways for EMAS and 111 services. I think the other thing which has always been a difficulty, and there's good reasons for it, around information sharing. And so building the technical links to allow information to go through the service so that patients don't need to repeat their story and it's understood what's happened to them previously in their pathway is really important, and we're working on that as well. And obviously, just as we're trying to ensure that the population patients understand what 111 can offer, we're also supporting staff so that they understand the range of services that are available to them to use for the patients too, because that keeps changing and keeps needing to be updated. So I think it's important to just understand the breadth of service and the alternatives that are available to support urgent care needs, and those are much broader than simply A&E itself. We can move on, Claire. So in practical terms, we'll just sort of say what's actually different, and this perhaps repeats a point that Claire made earlier. But if you ring or contact 111, there is a national agreed algorithm of set questions to make sure that you don't have a life-threatening emergency, because if you do, you need to be identified quickly and rapidly, and then your care moved across to the ambulance service, who can appropriately dispatch an ambulance if that's required. But if it's a non-life-threatening need, there will be further questions to understand the nature of the problem and what your need is. And that then leads to a series of different responses. So that will be advice simply as to how to manage the problem yourself, which is relevant to a good percentage of the people that actually contact 111. There may be advice that your care can be delivered by getting medication from a pharmacy. If it's a mental health problem, you can be directed to the mental health crisis helpline. Or if there needs to be just more detailed understanding of the issue and more senior discussion, and that goes through to a clinical advisor who's normally an advanced nurse practitioner or GP, and there may be a video consultation to back that up and ensure that that's safer and secure. And then at that point, if a person will benefit and requires a face-to-face appointment, then there are slots available, as we've said, both in UTCs, general practice services, A&E itself, or potentially into a same-day emergency care slot, that's called SDEC, so that you would go to a department in the hospital that would service that particular problem directly. So it gives essentially a real opportunity to get directed to the right place for the problem itself. If we just move on, Claire, to the next slide. So in terms of what's different, previously, I think, particularly in the use of A&E, people would self-determine where they perhaps thought they would go, and they sometimes weren't sure because it was a sort of immediate problem that had emerged and there was a default response. Whereas actually now, if you ring 111, you will get a booked slot, and that is better for you. And it's also better for the service because it knows you're coming and it will have the information to inform the thinking around your care when you arrive. In addition to that, patients that just turn up to A&E or to a service such as a UTC without calling 111 may well have to wait that little bit longer in order to have their clinical assessment done and to understand what the need is. And so it's actually in people's interest to contact 111 and get a slot that's at a time that is helpful for you and helpful for the service as well. And that information transfer, which is in the third point, I've already sort of mentioned, but it's really helpful to clinicians when someone emerges in front of them to actually know what the story is, what the issues are. If we just move on further, really, I think it's just important to say that this is not just, I think Claire alluded to it earlier, but it's not just a telephone service. There is online access too, and online access suits a whole range of people and different demographics. And again, there's a nationally agreed, mandated and safe triage tool available for patients when they go online through 111, and a lot of people are often very satisfied with getting the information that they can get from 111 online. Now, not all services are yet available through online booking, and we're having to just work very carefully through the issues of this because we want to ensure that patients using that service actually get to the right place for them and for everyone. And so there may well be input of clinical advice just to support the actual disposition of where the patient goes to when they're accessing online. If you just say a little bit more on the next slide regarding 111, it is available 24 hours a day, every day of the year, 7 days a week. It's free on your landline or mobile, and it's also available online, as I've just said. But there's also accessibility features necessarily built in for equality purposes for folk who have difficulties with communication and hearing or language. So in the slides, which you've all got access to, there's more detail about that. But we're very cognizant that not everybody is going to be slick online, and people will have communication difficulties that will need to be attended to. If we move on to the next element, I think it's really just to understand how the UTCs fit into the system, and perhaps pick up on one of the questions that was in the chat, really, about so what is the specific benefit of going to a UTC rather than say going to an A&E itself. So the actual service itself, which I'm sure many of you are familiar with because they are dotted around the county, are essentially specialist nurse led with access to GP support, and they're open 12 hours a day at least, and you can get access to them through 111 or via a GP referral as well. And they're basically there to deal with minor complaints, minor illnesses, minor injuries. And they do have access to more enhanced diagnostics than you will have in a general practice, such as X-rays and various diagnostic blood tests and so on. You know, on the spot diagnostics, and they're much more accessible in some ways than travelling to an acute setting, such as CRH or Royal Derby. And so they can be a very useful part of the landscape of care. And I think there's often been a question of people not being exactly sure what they're there for them to do, and consequently sometimes literally driving past the UTC on their way to A&E. And by using 111, you may well, you know, get care closer to you with the appropriate level of diagnostic service and knowledge to manage it quite effectively. And certainly in the past, quite a lot of the people who have emerged at A&Es have had conditions which do not require the high-end services and care that is what an A&E is about, which is for significant emergency care. So essentially, if you're not sure whether or not the UTC is the right place for you, just ring 111 first, and that will determine whether actually you can get the medication or cream or whatever you require from a pharmacy, or whether you need to go to a UTC, or whether in fact you do need to have an appointment at an A&E. And if you do require that, then you'll be given a booked time slot. If we move on to just the next steps of our thinking, really, and that's really just building on what I was discussing earlier, which was this same-day emergency care. There are a lot of conditions which require enhanced specialist expertise and diagnostics to determine what the issue is. And with putting those all together, you can see the patient and get them through the hospital setting within the same day, and they do not require admission to a hospital bed. And we want to build up the number of conditions for which the service is set up to work those particular pathways and those particular conditions through. And this is also really important and increasingly important regarding frail patients and elderly patients who often do not benefit from staying in hospital for lengths of time simply because of the demands on them physically from being in hospital. And if there can be a real wraparound understanding of their care needs and their position and support that they have in their own home, often frail patients do not need to be admitted, but can be supported, the issue dealt with, and then back home with support. So ensuring that we get a really fuller frailty service that can be accessed by 111 and ambulance services is really important for the population. I think the other thing that is changing too, and this is partly a response to the pandemic, is just the aggregation of work in general practice and in primary care. So on-day care is more consistently done through a triage duty team, handling the bulk of calls on the phone and seeing people either on video consultations or in the surgery face-to-face. And that is being aggregated to, particularly in out of hours or extended hours sessions, across patches of what are called primary care networks, which are groupings of general practices working together. And just as 111 clinicians can access slots in A&E, there are occasions where GPs would find it helpful and it'd be beneficial for their patients if they could access a slot in a UTC or A&E. And so we're looking for that conduit to be built as well. And further on from that, getting access to some of the community services for EMAS and 111 could be very helpful. So sometimes you'll have an elderly person who simply is struggling to move around their house or get in and out of their bath or something like that. And actually, by getting a rapid community response, that will prevent them being admitted or going through an acute setting with all the demands on them physically and psychologically that entails. So building these links is really important. And picking up, I think, on one of the questions, I think, from Phil there about how often are the services reviewed and updated. Behind all of these services is what's called a directory of service. So when you have a patient that has contacted 111 and then there is a disposition to go to a particular service, it is clear from where the person is that these are the services in their area and these are the times they are open to, and therefore we can slot you into that position. And there is an ongoing regular and dynamic updating of directory of service to ensure that it is current and relevant to the call handlers and clinicians so that patients get to the right place consistently. So essentially, 111 First is a very key part of getting this integrated approach to urgent care in the county and across the country as a whole. So on to the next slide, which is just building on the we need your help, which Claire raised earlier. And it's basically, we need your help because it will be very helpful to use 111 because you will get a good initial assessment, you will get a clinician advice if required, you'll get a booked appointment in the right setting, whether it be a UTC, general practice, or an A&E, and you can get, if necessary and if it's appropriate, simple signposting and self-care advice, or access to your general practice services or hub. So this is a very helpful way of progressing service and trying to ensure that patients are in the right place and receiving the right care. So I think Claire and I have probably talked far too much, and we've got many questions, I'm sure. So we'll welcome any comments or thoughts that folk may have.
Hi, Paul. I think you answered Chris's question, which was around when should I go to Chesterfield and when should I go to Whitworth Urgent Treatment Centre as opposed to going to the Accident and Emergency Department. I think you answered that, didn't you, as you were going through? But Claire, there is a question from Anne around, we have many elderly patients in Dromfield who don't have transport. What would happen for the patients who need to go to an urgent treatment centre?
I think that's a really good question. And what we have found is when people have urgent care needs, that they generally are able to find a friend or a relative or pay for a taxi that can take them there. And if they can't, then that's a genuine discussion to be had on the call to 111 call handler about the distance between where you live and the services that are available. There may be another service that's available to meet your needs. So again, that's another factor that can be taken into consideration during the call with 111. Paul, would you add anything to that?
No, I think it's a complex question, and there isn't a simple answer to it. Partly because the accessibility of services is not just a issue for folk in rural parts of the county or in areas who traditionally don't have particularly good public transport services. There are also groups and populations in the city of Derby who live sort of off the grid of bus routes, or have real difficulties through their social and economic background to accessing a lot of services. So I think Claire's point that a lot of people do actually have neighbours or colleagues or friends who will pull in and support at times of need is quite important and makes a big difference in these circumstances. And I think we people are aware of it, and therefore having a directory of service that understands what is local and what is best for you is important with this. But there isn't an answer, and clearly it isn't a health service responsibility to transport patients to particular settings unless they have really a medical situation which means they have to be transported.
Thank you very much. There's been some discussion in the chat box as well about living in Buxton, and that the nearest hospitals are Stepping Hill and Macclesfield, sorry. And so it was just about if you lived in Buxton and thinking about the closest proximity to hospitals, which would be the best urgent treatment centre that you could be directed to.
So this is another benefit of calling 111 first that we perhaps, I think Paul touched on, but we didn't explain, and that is the directory of services that sits behind it that Paul was talking about, that's constantly updated. If you call 111 first, one of the first things they take once they know that you're not an emergency is your postcode, and then they align the services that match your postcode. So for me in the south of the county, I border Nottingham and Derby, and sometimes it depends which service I need as to which one will pop up, but it's based on your postcode, and Stepping Hill and that direction of services may actually be the one that can meet your needs and is the closest. So it's all done on postcode basis, which is partly why in Derbyshire we have our services spread around the county. But we are also where there are some on the borders, and that the directory of services will pick up those that are across the borders. It's not the Derbyshire directory of services, it's a national one.
Thank you very much. And Paul, Pat asked, we need pharmacy availability attached to the urgent treatment centres?
Well, I think there's lots of different ways of handling that. So traditionally in out of hours services, if you were seen out of hours, you were often provided with a short amount of tablets to get you started or cover the initial part of your care. I think the other thing which is now really sort of taken off and makes life very much easier is electronic prescribing and the ability to prescribe to a chemist that's close to the patient, because quite a lot of these interactions are, as we've said, on telephone or video, and so in my day-to-day working as a GP, but also in an out-of-hours setting, if you have someone who is ringing up and they've got, say, a straightforward water infection, you may not need to see them, but they do need some antibiotics. and you can see in your computer through the postcode where they live and where an open pharmacy is, and you can electronically prescribe a prescription that they can pick up from the pharmacy close to them. So that's making a real difference in terms of the actual practicalities of receiving care if you need medication in response to the condition.
Thank you very much. We've had.
Can I just add, Katie, on the pharmacy one as well? The pharmacists are now profiled on the directory of services too. So if you ring 111 and it is deemed that a pharmacy can meet your needs, they will be able to tell you which one is nearest and which one is open. So as long as the pharmacists have kept up to date with their updates on the directory of service, which we can't be fully responsible for, but we do send out regular requests to keep it up to date, then that's another route of finding out which is the one that can meet your needs.
Thank you very much. Val, I know you've raised your hand. Would you like to unmute your microphone? Have you got a question to ask?
My concern is when 111 say that they take the information and then say, we'll give you a call back almost immediately with a doctor or someone else to discuss the problem with you. I had occasion a couple of years to use that system, and after 3 hours, I rang them back to say what was happening. And they'd been trying to ring me, but we had a call bar on our phone system, anonymous calls, which a lot of people have. And because they're ringing through a switchboard, it comes out as an anonymous call and the phone system rejected the calls. And I think that's something that 111 could accept, that if they don't get an answer, that it may be the phone is rejecting it. It works the same from the Royal Derby Hospital. When calls go out, people don't answer anonymous calls, and so they have to go on a separate line. I don't know if anyone's picked that up before.
It's certainly not come to our attention as an issue, but we will go and look at that, Val, and thank you for raising it. I think that there's two parts to it. There's, if you haven't got the call screen and you know you're waiting for a call back and it's an anonymous, please consider answering it if you know you've called 111 and they're calling you back. But if you have got a call screen, then what we'll do is we'll speak to our 111 call provider and see if there's a prompt question. We can check whether that's going to be an issue or not. Thank you.
Thank you.
And Philip, would you like to, I know you've got your hand raised, would you like to unmute your microphone?
Yep, thank you. I know a number of GPs have got out-of-hours services. Are they working in conjunction with NHS 111, or are they just a separate entity, or are they going to be improved and included?
A lot of our GPs out-of-hours services are predominantly run by DHU, which is the same company that runs NHS 111 First. And so it's kind of a separate entity of the same company, but they're brought together through 111 First. So should you require an out-of-hours appointment at your GP, sometimes that appointment will be booked for you by your daytime receptionist of your main GP. And if it's an out-of-hours need and you call up, say, 9 o'clock at night through 111 First, they can book you into the out-of-hours appointment directly through that service.
Right, thank you.
Does that answer the question?
It does, yeah. Yeah, thank you.
Paul, there was a question from Janet. They work for the Dementia Rapid Response Team, and we'd like to ask, they want to say that a lot of their patients don't have access to the internet or video. Would they miss out on the consultation?
Well, they would still have access through the 111 telephone approach, and so I think the question partly depends on the capability and capacity of the individual with their dementia, and often patients with dementia, the issue is often being dealt with by a carer or family member, so who may have stronger availability or fuller access to those sort of services. But it's important that everybody has access, and that's why there is the access issues that approaches that I mentioned in the presentation itself. I think what is helpful to perhaps, and it picks up on one of the other questions about does 111 have access to patient records, and what a lot of services, including GPs, do is can write specific, with the consent of the patient and the family, information and special records and notes about the individual. So, and this is really important in patients with palliative care needs, or patients with, say, dementia, which may at times be made worse by an acute infection, say a water infection or something like that. And you as a GP will provide information about, this is the sort of general baseline of this person. This is how they tend to present when they're becoming unwell with an acute infection. These are the people to contact if this person contacts us, because they support this person in the community with their dementia or with their other health needs. So there isn't full access to records. There can be agreed access if that is consented by the patient themselves, but the opportunity that comes from having those sort of bespoke information plans shared with 111 and our services can be really, really helpful for the clinician trying to deal with the problem, but more importantly for the person themselves, that they are understood and known, and therefore you get a more appropriate response to the the concern.
Okay, thank you very much, Paul. Claire, there was a message from Val about, obviously this is a really good idea, but a lot of people don't know about the service or fully understand it. And their suggestion was, can we get it on East Midlands today or through social media? And I know there is some work around marketing and advertising 111 first. So I don't know if you just want to update on that.
Yeah, absolutely. So there are local communication campaigns and national communications campaigns. And from the 1st of December, the national comms campaigns went live. So if you watch ITV, Channel 4, and some providers like Netflix, you will see an advert pop up that says call NHS 111, but it doesn't really explain necessarily what it is. On the adverts on the telly, there's 3 different scenarios. So somebody being mildly unwell, somebody falling off their bike, but it's not a broken bone, but might be some scrapes or sprains. And I think there's a child-related scenario too that goes into it. And they're running those campaigns all the way through until March. Locally, if you follow any of our main providers on Facebook or Twitter or other social media, so the 2 acute trusts, the Chesterfield Royal Derby, if you follow Derby and Derbyshire CCG, if you follow Derbyshire Community Health Services, they all have messages now on about NHS 111 first and the urgent treatment centres, and when to choose which service to use, and some scenarios now about when to use that. We appreciate that's not going to capture as many people as we'd like. We've had our own Paul Wood, who's on the call today, starring on one of our BBC News interviews just before Christmas, I believe, stood in the rain outside of Royal Derby. And I believe there are other people around the patch from Nottingham and Leicester also doing news reports that we will see in the East Midlands on our East Midlands News. So we are working up further plans to try and get onto the radio and trying to get into things like parish newsletters to get us known as much as possible, because this is really key and really important. We'll never get everybody. So actually the ask on this call is, there's a large number of people here. Please go and spread the word and help to be part of our communication channels, because it's going to be really, really effective. The more people we tell and the more personal the message is, the more likely people are to remember it than a quick advert that they saw looking through a newspaper. So it's a real plea really of not just help us to help use the right services, but please help by spreading the right messages too.
I think in relation to that as well, Claire, Val was saying, could all GP practices email I'm assuming the information out to any of their patients where they hold an email address for them?
We can certainly put it down the route of GPs. We've had really good engagement from our GPs with 111 First, because clearly we've had to link up how to book from 111 First into a GP appointment, for example, and we have been sending out regular information. I think the challenge at the minute is timing, because our GPs are incredibly busy with the vaccination efforts, and so additional requests on their time may take them away from that is equally and incredibly important. So we'll absolutely take it on board and give it back to our comms leaders as a recommendation, and we'll see what we can do. So thank you for that suggestion.
Thank you. And I think, Paul, that you answered Chris's question earlier. There was a question in the chat box about access to patient records. I think you covered that, didn't you, about the services being able to access patient records?
Yes, I think I gave us a sort of thumbnail sketch around that. The issue with general practice is that you hold the full patient record, which is a very comprehensive set of information, which is sort of actually very unusual in the whole of healthcare globally, actually, as a construct. And so that isn't all visible. There is essentially a visible element if patients have consented to it, with basic information about key drugs, key allergies, key conditions. But as I say, I think the most useful part of information sharing is the information that you have around the care plans for frail elderly patients, patients with dementia, patients in care homes, and palliative patients, where it's really important that the other services understand what position is, and certainly as a working GP, one of the things I'm constantly doing is trying to build that information around patients who I think are at risk of having their care escalated into other care settings, and trying to ensure that the care they receive is really appropriate, really. So that is something that is actively managed within practices, but certainly not the whole record is available for practical reasons, just because of the volume of data that's there.
Yeah, because I think there's quite a few on the similar thing. John's also saying, would it not be better to give 111 medical consultants full access to medical records?
I think I don't think that is the a way to go, really. Simply because the volume of information that is available there. So it's much more important to have access to key diagnoses, key medications, key allergies, and access to the active medical recent problems. And so the issue of sharing of records is actually quite complex, and it is not a straightforward thing. But I think what is important with this program is that if you have contacted 111 and have given your information and details of the current issue, that information will follow you through to where you end up being seen, and that's really quite helpful, and I think is where we need to be at present.
Thank you, Janet. No, you've got your hand up, Janet. Did you want to ask a question?
We were just wondering, I understand GPs and everything are really busy, but a lot of our patients who have dementia or different, with the information about the 111 services.
I think we missed some of that, Janet. I'm sorry. I think you might have frozen for a minute. Do you want to just run through that question again? Sorry.
we were just saying, a lot of our patients, it would be beneficial if they had something visually with the 111.
Yeah,
going to look after them or family.
Yeah, I'm sorry,
Some
Janet.
of them don't have
cutting out. Would it? Is it
you know,
possible? Thank you. So yeah, there's just lots of ideas appearing in the chat box. Claire and Paul, I don't know if you've seen it. Somebody said they used to work for EMAS as a technician and advertising on the side of the ambulances. So there's lots of good ideas about how to market it. Could you text patients about it?
Yeah, we'll absolutely take those back to our communications lead and make some recommendations. Thank you.
Janet, did you want to type your message, because you kept cutting out? I'm sorry. Anyway, what I'll do is that there are no more questions in the chat box just while you're typing, Janet, just to say thank you very much, Paul, to you and Claire for coming to this session today. It was really enjoyable. As always, any late questions, we're very, very happy to answer them. And also to say that our next session is around long COVID and the services, the impact that long COVID has had on some of the patients in Derby and Derbyshire, and the services which were the pathway that will be put in place to deal with some of those conditions and complications that have arisen after having long COVID-19. That session is on the 12th of February and it's 10:30 until 11:30. I'll just see if there are any last minute questions. Just have a look. Janet said, for patients that don't have email or mobile phones, would it be possible to be sent a visual leaflet?
Again, we'll have to take that back to our communications lead. It's a really good idea. I think sometimes it comes down to the cost versus the value of sharing leaflets across the 1 million people who live in Derby and Derbyshire. But it's one of the routes that we would definitely consider. Thank you.
And I think, another suggestion, Paul, about would it be useful to get 111 first as a discussion on the PPG agendas, so that they could share it? Perhaps that's something we could do through the PPG forum, which has started, and ask PPG members to share. So I think, Miriam, unless I've missed anything, is that all the questions?
That's everything. As I said at the beginning, we will check the chat box, and if there's anything we've missed, we will come back to you. So thank you so much for all your questions, and yeah, big thanks to Paul and Claire for your time this morning. It's been brilliant. And
John, I noticed did you just shoot your hand up there in the final minute?
Yeah, I was just going to say on that last point, you know, if you send, as you do, send these slides through, then what I do, certainly I'm sure other people do, is simply forward them to the other people in the PPG. I mean, then they can come up for discussion when you have meetings, but it does make sure everybody sees them.
That'd be great. Thank you, John.
Thank you, John.
Thank you.
Anyway, again, thank you very much, Paul. Thank you very much, Claire. And thank you very much to the people who've joined today. We really appreciate it, and we hope you've enjoyed the session, and we look forward to seeing you at the next one. Thank you very much indeed. Enjoy the rest of your day. Thank you.
Thank you all for your time.
Thank you.
Bye-bye.
Thank you.
Bye-bye.
Yeah, bye.